Pre-Eclampsia. Okay. All right. So, if you look at what I've written on the board, hypertension in pregnancy, two things come into mind. Hypertension, pregnancy. Yes. Who can give us a definition of hypertension? And this time around, we should bar the diabetic aspect of it. Yes, Nafisa, go ahead. Yes, it's right, except that you didn't comment on whether the patient has been previously normotensive or not. Okay, if you remember very clearly, we made claims that hypertension can be defined, per the definition. It's defined as what? A clinical condition, characterized by sustained elevated systolic blood pressure greater than or equal to 140 millimeters of mercury, and or the diastolic blood pressure greater than or equal to 90 millimeters of mercury in a previously normotensive patient measured 2 consecutive times at least 4 to 6 hours apart. Right? So when we are defining hypertension in pregnancy, we will give that definition and we'll add in pregnancy. Is that clear? Are we getting that? And that definition will work if only there was not a previous blood pressure taken. Are we getting that? In that circumstance, if the patient comes and there was no previous blood pressure recording, then we'll stick with that. Okay? Meaning that will be patient comes, there's no previous blood pressure recording, we'll go with that. Are we getting that? But if patient comes and there has been a previous blood pressure recording, then there's another definition that we can go with. That will be the change in the values. Okay? So if there has been a previous BP recording, which was done let's say 4 to 6 hours apart, done 4 to 6 hours ago or a day ago, okay? And the patient comes and you check the blood pressure, okay? Then you can make reference to what? That initial blood pressure that was recorded. Are you following? And that one, you'll be using the difference. And the difference with regards to the systolic blood pressure should be greater than or equal to 30 millimeters of mercury. And with regards to the diastolic blood pressure, should be greater than what? 15 millimeters of mercury. Are we getting that? So if there has been an initial recording, okay, yes, you can find the difference, okay? But if the patient is coming de novo, then of course you are supposed to check the blood pressure 2 consecutive times, 4 to 6 hours, at least 4 to 6 hours apart. Is that clear to you? Is that clear? Okay. Now let's move on. So now, when we say hypertension in pregnancy, it's so broad. Okay. So the next thing we are going to do is that we are going to look at the classification. Then with the classification, we'll be seeing how the breakdown will look like. Okay. Then with that, we can make reference to the gestational age of onset. And we'll be using the gestational age of onset of the hypertension to distinguish between the various types. Is that clear to you? All right, so let's move on. So with the classification, and you should also remember that hypertension can also be defined in terms of the mean arterial pressure. Remember, where we said that if there has been an increase in the mean arterial pressure by what? 20, by greater than what? If there has been an increase in mean arterial pressure greater than 20 millimeters of mercury, we can also consider it as hypertension. Or if there has been an increase in a mean arterial pressure greater than 105, greater than or equal to 105 millimeters of mercury on a single occasion, then we are looking at what? Hypertension again. The increase in the mean arterial pressure by more than 20 millimeters of mercury, it is when you have done the recording twice. Are we getting that? But if it's on a single occasion, if you have it on a single occasion, then you'll be using the 105 as a threshold. Is that clear? Mean arterial pressure greater than or equal to 105 millimeters of mercury on a single recording is hypertension. Mean arterial pressure, increase in the mean arterial pressure by more than 20 millimeters of mercury on 2 recordings is considered as what? Hypertension as well. Is that clear? All right, now let's look at the classification of hypertension in pregnancy. So with the classification, we will have chronic hypertension, we will also talk about pregnancy induced, meaning that the hypertension is caused by it's as a result of the pregnancy. If not for the pregnancy, it will not be there. Okay? Pregnancy induced hypertension, which we will say PIH. Okay? These are the two main types of the hypertension in pregnancy. But again, we can have other types which would look like a blend of the two. Okay? So the third one we will see chronic hypertension, superimposed by pre-eclampsia or eclampsia. Then the last one, we'll say unclassified hypertension. Unclassified hypertension. What we are going to do next is to look at each and every one of them with regards to what they mean. Then when we are done with that, we would focus on pre-eclampsia as our main stay. Okay? Okay, so let's begin with chronic hypertension. Chronic hypertension. Chronic hypertension. Chronic hypertension. All right. Chronic hypertension. Chronic hypertension. So from the beginning, I made mention of making reference to the gestational age of onset, okay? And when we are talking about hypertension in pregnancy, with the classification that we gave, with regards to chronic hypertension and pregnancy-induced hypertension, there is going to be a difference with relation to the threshold of onset, the threshold with regards to what? The gestational age of onset, okay? And would explain further when we get to the pathophysiology or pathogenesis of what? Pre-eclampsia, where you will see the various theories or suggestions explaining the mechanism. And you should know there's no exact mechanism explaining pre-eclampsia. They are only in what? Theories, suggestions. We'll look at a couple of them, such as the invading cytotrophoblast mechanism. We'll be looking at the angiogenic and anti-angiogenic factors. We'll also talk about the immunological mechanisms, okay, with regards to how preeclampsia happens, okay? Okay, so now let's begin. Chronic hypertension. If you look at chronic hypertension, we'll say that, refers to hypertension, okay, occurring at a gestational age less than, okay, so let's put it this way. Hypertension, okay, occurring at a gestational age, yeah, less than 20 weeks, okay, meaning that the onset of the hypertension is less than what? 20 weeks. Are we getting that? Are we following? Less than 20 weeks. So hypertension occurring at a gestational age less than what? 20 weeks, and can persist beyond the puerperal period. And we know the prepubertal period, we'll consider it as what? 6 weeks postpartum. After delivery, from delivery up to 6 weeks, yeah, we'll consider that as what? The prepubertal period. So for chronic hypertension, its onset is before 20 weeks of gestation and can persist beyond the prepubertal period. So if it's persisting beyond 6 weeks, okay, we can say it's chronic hypertension. If its onset is before 20 weeks of gestation, yes, you can consider it also as what? Chronic hypertension. Is that clear? Is that clear? That is the more reason why when a pregnancy is associated with hypertension, okay, and after delivery, it persists beyond the prepubertal period, it no longer becomes an obstetric management. It no longer becomes an obstetric requirement. It will rather be referred to what the physician to manage as hypertension, which in this case we'll call chronic hypertension. Chronic hypertension simply means that it has nothing to do with the pregnancy. It was preceding the pregnancy. It was there before even the pregnancy happened. Are we getting that? But if the pregnancy is, if the hypertension is coming as a result of pregnancy, or the pregnancy is precipitating the hypertension, then we'll see pregnancy-induced hypertension. Are you following? Okay, so chronic hypertension, as I said, the onset of hypertension is before 20 weeks of gestation and can persist beyond the prepubertal period. Is that clear? Okay. Now, pregnancy-induced, so that's for chronic hypertension. And next one, pregnancy-induced hypertension. Pregnancy-induced hypertension. So, pregnancy-induced hypertension, we will say that the onset of hypertension, for pregnancy-induced hypertension, onset of hypertension, okay, or the hypertension occurs after 20 weeks of gestation. The hypertension occurs after 20 weeks of gestation. That's the onset, is after 20 weeks of gestation. And does not persist beyond the prepubertal period, meaning that hypertension will resolve within the prepubertal period. Are we getting that? Are we following? Mm-hmm. Meaning that hypertension was as a result, or is as a result of the pregnancy. And we can make a relation with that, in such that without the pregnancy, that hypertension would not have what? Occurred. So we are saying pregnancy induced. The pregnancy is causing the hypertension. Are we clear on that? All right. So with the pregnancy-induced hypertension, we can have, subtypes. Okay. For the subtypes, we'll talk about it when we are talking about pre-eclampsia. Okay. So for the subtypes, we can think of one, gestational hypertension. Gestational hypertension. 2, pre-eclampsia. 3, imminent or imminent eclampsia, or what we call fulminant pre-eclampsia. But this particular type is no longer, referred to. It is considered as a severe pre-eclampsia. When we get there, we'll comment on that. And the last one will be eclampsia. So when we are done with this, we'll come to pregnancy-induced hypertension as a topic, where we'll be focusing on pre-eclampsia. Okay? Okay. The next one, chronic hypertension superimposed by preeclampsia or eclampsia. What that means is that the onset of hypertension is before 20 weeks of gestation, okay, accompanied by proteinuria after 20 weeks. That becomes chronic hypertension superimposed by preeclampsia. I'm saying that for chronic hypertension superimposed by preeclampsia, the onset of hypertension is before 20 weeks of gestation, followed by or accompanied by proteinuria after 20 weeks of gestation, meaning that the onset of proteinuria is occurring after 20 weeks of gestation. Is that clear? Are we following? But if we are saying chronic hypertension superimposed by eclampsia, then that automatically means that onset of hypertension is before 20 weeks of gestation, followed by what? Seizures after 20 weeks of gestation. Are we getting that? Are we getting that? Because eclampsia basically is pre-eclampsia with what? Generalized tonic-clonic seizures. Okay? When we get to pregnancy-induced hypertension, we'll be commenting so much on that. Okay. So chronic hypertension superimposed by pre-eclampsia and or eclampsia. If it is pre-eclampsia, we'll say chronic hypertension superimposed by pre-eclampsia is when the onset of hypertension is before 20 weeks of gestation, followed or accompanied by proteinuria after 20 weeks of gestation. And if it is chronic hypertension superimposed by eclampsia, we will say that onset of hypertension is before 20 weeks of gestation, followed by seizures after 20 weeks of gestation. Are we clear on that? Okay. Then the next one, unclassified hypertension. So it means that should you sit for any exam, should you go for the exam, and they're asking you how would you distinguish between chronic hypertension and pregnancy-induced hypertension, or chronic hypertension and preeclampsia, which you know belongs to pregnancy-induced hypertension, or chronic hypertension and gestational hypertension, which you know belongs to pregnancy-induced hypertension. You can simply use what? The age of what? The gestational age of onset, and even the duration. Would it persist beyond the prepubertal period or not? If it persists, then you know that it's chronic hypertension. If it's before 20 weeks of gestation, you know that it's chronic hypertension. If it is onset is happening, if the onset is after 20 weeks of gestation and resolving within the prepubertal period, you can also think of pregnancy induced, in which case could be gestational hypertension, pre-eclampsia, and the rest. Are we clear? Okay. The next one, unclassified hypertension. With the name, unclassified, we don't know where it belongs. Are we getting that? Are we following? We don't know where the hypertension belongs. So in that case, we'll say that with unclassified hypertension, the patient definitely is not a regular or has not been to the antenatal care or has not been regular at the antenatal care clinic. So, patient comes to the ANC after 20 weeks of gestation with hypertension, and we don't know whether the onset of hypertension is before 20 weeks of gestation or it is after 20 weeks of gestation. Please do you get that? It means that the first time the hypertension is being elicited was after what? 20 weeks. It's after 20 weeks of gestation. Now, we want to know when that hypertension, when was the onset? Is the onset before 20 weeks or after 20 weeks? Are we getting that? Are you following? So in this case, we say that patient presents with hypertension after 20 weeks of gestation, of which the onset is unknown. Of which the onset is unknown. So if the onset, yes.
What if she has proteinuria too? She's still classified as unclassified hypertension.
If she has
proteinuria after the 20 weeks.
Yes, again, we don't know. First of all, we need to know when the hypertension started. So in that case, it could be a chronic hypertension superimposed by what? Pre-eclampsia, which we are not aware of. Because we don't know when the hypertension starts. We don't know when the hypertension started. So if you are able to know the onset of the hypertension, then everything becomes simpler. You'll be able to classify. But here lies the case, we don't know when the hypertension started. We don't know whether it started and now being accompanied by proteinuria. Okay? So, to reclassify, what can be done to reclassify the hypertension? So if you have a scenario like that, there are some parameters that you can take into consideration to reclassify the hypertension. So the first one, in that case, you can do a lab, serum uric acid. Serum uric acid. Serum uric acid, okay? So with serum uric acid, the levels will be elevated if it is a pre-eclampsia or pregnancy induced. Are we getting that? So in pregnancy, should you check the serum uric acid levels, okay? The normal limit can be gotten by, okay, multiplying the gestational age at which the serum uric acid is being checked by 10. You multiply the gestational age at which the serum uric acid is being checked by 10. You don't use the normal limit which is given by the lab. You know, for every lab, you will see by the side normal limits. Then they will put there some values. The normal limit for serum uric acid varies from lab to lab. We could have it around 250 getting close to what? 400. Or from 220 getting close to what? 400, like 230 to 360, or you could have 250 to 400 or 250 to 350. It varies, okay? So with pregnancy, you are not going to be making reference to the normal limit given. You would rather have to what? Calculate the threshold. Are you following? You rather have to calculate the threshold. And how do you calculate the threshold? By multiplying the gestational age by 10. Whatever value that you've gotten becomes the threshold. So the next thing you'll be looking at is what value is coming from the lab. Remember when we were talking about neonatal jaundice? Remember, to get, for phototherapy, you know, for term babies, the threshold is defined. For term babies, it should not be greater than 240 micromoles per liter. But if a preterm baby comes, how then do you do that? You have to calculate the threshold. A similar thing that we are doing here. So you multiply the gestational age by 10. That should give you the threshold for serum uric acid. So now the next thing you'll be doing is looking at the lab values to check if it's within this limit or greater than this limit. If it's greater than this limit, then you'll be thinking of something. If it's within the limit, then you'll be thinking of something else. Are you following? So now let's take an example. Patient is 30 weeks. Came at, let's say 25 weeks. Patient came at 25 with hypertension. We don't know where to classify hypertension. Now you requested for serum uric acid. So 25 weeks, you multiply it by 10, that will give us 250. Okay? 250. Now, you requested for serum uric acid. Serum uric acid comes and it's 300. This is the lab value, it's 300. Okay. It comes as 300, let's say millimoles per liter. Okay. It came as 300. And the lab is telling you that the normal is 250 to 380. Would you say that this is normal? Because if you don't use this principle, you'll be forced to say this is normal. But it's not normal because it is with reference to the gestational age. So if you look at the gestational age 25, the threshold should be 250. But here lies the case, the lab requested gave us what? 300, telling you that serum uric acid is what? Elevated. And the serum uric acid can only be elevated if it is a pregnancy-induced hypertension. Are we getting that? Are we following? So if you request for serum uric acid and it is elevated, then you are thinking of what? Pre-eclampsia. Are we following? But if you check the serum uric acid and it is normal, okay, or slightly reduced, it's normal, or slightly decreased, then you are thinking of what? Chronic hypertension. Is that clear? Is that clear? I hope we get that. Okay. So it tells you that serum uric acid would increase with preeclampsia, but does not. do so with chronic hypertension. So in that case, if you check and the serum uric acid comes out and it's elevated, then you will say this is what? Pre-eclampsia. And in that case, what have you done? You have reclassified the hypertension. Is that clear? Another thing that you can do is to wait, but that one it can be costly. Resolution of hypertension. So another thing that can be considered is if the patient comes close to term, let's say he came at 36 weeks of gestation and the worst happened, okay, and the baby is delivered, then in that case you are supposed to be monitoring to check when the hypertension will resolve. If the hypertension resolves before the puerperal period ends, then you say that is what? Pre-eclampsia. But if it persists beyond the puerperal period, then you will say that it is a chronic hypertension. Is that clear to you? Please, do we get a classification? Do we get a classification? Okay. Then, let's move on to, yes, please. Yes. Tell me, if it is increased, it's only in pre-eclampsia that you are going to be having the serum uric acid increasing, because there's going to be what? Increased cell turnover in pre-eclampsia. And if there's increased cell turnover, I mean the cells are dying or breaking down, serum uric acid will be released, which will not happen in chronic hypertension. So in chronic hypertension, the levels will be within the normal limit, or maybe slightly decreased. Slightly, not decrease as in markedly decrease, slightly decrease, or normal. That becomes chronic hypertension. But if the serum uric acid are elevated, as I said, beyond the threshold, which we calculated by using the gestational age multiplied by 10, then you are looking at what? Pre-eclampsia. Please, is that clear? These are technicalities that you would have in practice. Yes.
The resolution, did you say it resolves within the puerperal or?
If it resolves within the puerperal period, it becomes more of pregnancy induced. In this case, we are saying pre-eclampsia. But if it persists beyond it, then you are thinking of what? Chronic hypertension. Please take note that this usually almost always comes in exam, any examination. So you are supposed to know. And I believe you are obedient and would revise and be able to ace the exams without any resistance. Even when Ohm's law is being expressed, we'll put the resistance as a what? Constant. It will not increase. It will be minimal to nothing, so that we can have our potential difference. And if you have potential difference, what will happen? Current will flow, electricity will flow. It means success will flow. Yes, let's move on. Yes, go ahead.
Can it lead to the demise of the patient while you are still monitoring? Or while this is going on?
Definitely. Yes, of course, you'll be managing.
Okay.
Managing. So that can still be monitored. You'll be managing. Okay.